I welcome you all here for a very short session about one of the very prevalent condition, that is about the respiratory tract infections. Respiratory tract infections are very prevalent when it's winter. Obviously they are there in summer as well, but in winter they are very prevalent. I'll just be briefly overviewing, I'll just be giving you an idea of the commonest respiratory tract infections, how to pick the diagnosis based on symptomatology and very common and standard treatment protocols which will be following related to these infections. How a bug enters inside the human beings? The bug has got two routes. Obviously, most of these bugs gonna enter through your nostrils. As you will be inhaling air, they will enter inside your body. The second route is they can enter to the mouth route as well. So nearly all the respiratory infections, they are going to have this route as their antecedent event. Occasionally, the infection will be somewhere in the body and that can be disseminated to the lungs. But that's a separate entity. Our focus is entirely on these common respiratory problems which everybody faces during these winter months. So a bug has entered. What it can lead to? If a bug has entered, whether it is the viruses or the bacteria, and again I'll be focusing basically on viral infections and bacterial infections only. I'll not be giving you details related to some other infections like fungal infections or protozoal infections. Our focus will be on these two things mainly, the viral and bacterial infections. The bug enters inside our body through that respiratory tract. How it's gonna enter through the nostrils, say it reach to the pharynx, lately to the trachea, and then that can spread ultimately to the bronchi of the lungs and throughout lungs. And how it gonna present? Now, very small points, very few symptoms would lead you to that conclusion. What is the problem? What is the underlying problem? So how are we gonna reach it? Bug enters, affects two main areas basically. One is above the carina. We call it upper respiratory tract infection. And then the second is below the carina. We call it lower respiratory tract infection. So if above it, it involves the trachea, we'll be labeling it as tracheitis. It will be involving the pharynx, we'll label it as pharyngitis. If it will be involving the tonsils, we'll be calling it tonsillitis. If it will be involving the larynx, we'll call it laryngitis. And if it will be involving the sinuses, we'll call it sinusitis. And below that carina, if it is involving the bronchi and that infection is mild infection, we'll be calling it acute bronchitis. And if it will be involving our lung parenchyma, then we would be calling it pneumonias. So just remember these 7 things: upper respiratory tract and then lower respiratory tract infections. I'm just focusing on these 7 things: pharyngitis, and obviously all the acute problems. I'm not discussing the chronic problems here. Pharyngitis, laryngitis, tracheitis. The next is then tonsillitis. The next is then sinusitis. And here, the first one is acute bronchitis. And the second is pneumonias, community acquired pneumonias. That will be our focus. How we will be able to reach to conclusion, what sort of problem person is suffering from? One important thing, if a person has suffered from one of these problems, because all these things are related to each other, they are in continuum. What can happen? A person whose pharynx has been affected, the same mucosa is going ultimately to that trachea, so he can have tracheitis, he can have laryngitis. If it goes a little higher, it can lead to tonsillitis. Goes little higher, it can lead to sinusitis. So they are in continuum. They are the adjacent parts. It's not kind of dissemination which you need. The same way, if this infection goes down and involves the bronchi, that can lead to bronchitis, and lately that can ultimately culminate into some serious infection like pneumonia. I am giving you scenarios now. A young boy, 25 years age, comes to you, presents to you in outdoor, and as you ask what has happened with him, he presents you with symptom of that I am having sore throat from say last 2 days or 3 days. I am having bit of throat irritation. I am finding it bit difficult to swallow things, and I am having low grade fever. The answer is, in most of such cases, the answer is, if it's not complicated, the answer is acute pharyngitis. Again, I am not talking about those devastating complications of acute pharyngitis here, like a person is not able to speak, say, altogether. He is having some trismus and lockjaw along with this pharyngitis. He is having that much difficulty in swallowing that when you just open his say mouth and see his tonsillar pillars and pharynx, this is all filled with debris and exudates. So I am just talking about the minute problems which are the commonest ones, the commonest manifestations, not a complicated acute pharyngitis. The same person now claims that I am having hoarseness of voice. So this is how he would be telling you. And what has happened to him? The larynx has involved, that leads to laryngitis. Not necessarily that involvement or inflammation of the larynx secondary to viral infection or bacterial infection will be leading to laryngitis, but sometimes simply if you speak a lot, you raise slogans in a certain procession, teachers many a times, their vocal cords gets affected, and that can lead to laryngitis as well. But here we are discussing that laryngitis basically secondarily to viral infections or bacterial infections. Then the same bug can reach to trachea, and patient would be having irritation in the throat. There may be dry cough. Same dry cough can be there in pharyngitis as well, but there won't be any difficulty in swallowing. In the setting of tracheitis, the difficulty in swallowing won't be there, because you swallow through pharynx, which ultimately goes to your esophagus. The trachea is now a separate part. So the person with tracheitis would solely be having throat irritation along with dry cough, but there won't be any problem with swallowing, right? The next is then the two things, tonsillitis and sinusitis, the complicated ones. Now, out of 100 patients, the literature tells you, the literature review tells us, and actually this literature is mostly from the developed countries. So their literature tells us that in 90% of cases, the infection is going to be simply viral infections. And in 10%, these can be bacterial infections. The commonest bacterial infections are the gas. You understand about these organisms? Group A, streptococci organisms. So they are responsible for causing the pharyngitis. And if the infection is bacterial, there are certain things which help you to predict that probably it's bacterial, like if a person is running fever more than 100.4 or 38 degrees centigrade, suggests this bacterial infection. The conventional therapy doesn't respond to conventional therapy after 3 to 5 days, suggests it's probably bacterial infection. So there are few points, and obviously living in those areas endemic for these infections, bacterial infections, like our area, like India, like the third world countries where health is obviously not the priority. So in these countries, you succumb from these bacterial infections on many occasions and many a times, way more in comparison with the developed world. The fourth is then tonsillitis. The person, what would be the person saying? He would be saying that now, when I'm feeling that part, my lower jaw, palpating the lower jaw, I feel it bit tender. I am feeling there is a lump over that part. And when you examine, he feels tenderness. That person is having difficulty in swallowing, as well as high-grade fever with rigors and chills. This high-grade fever with rigors and chills is nearly almost always secondarily to this tonsillitis as far as upper respiratory tract infections are concerned, or complicated acute pharyngitis where exudate has been formed and significant pus has been formed. So tonsillitis, person with tonsillitis, jugulo-omohyoid and jugulo-digastric lymph nodes, they swell up, people feel pain here, difficulty swallowing, high-grade fever with rigors and chills. Sinusitis, how a person gonna present to you? A person, most of such people are again having viral infections in developed countries. In our countries, they can have these viral infections, but many a times these are bacterial, and the person who would be presenting to you gonna present as, most of such cases, preceding history of flu, in many cases, most important, nasal congestion and obstruction. If something is obstructing your airways, what it will do, as these are obstructed, the nasal secretion will pull up behind, and lately they're gonna pull up inside these cavities, empty spaces in your skull, which are known as sinuses, and ultimately leading to this sinusitis. So the most important point while treating these patients is to manage that obstruction. Otherwise, this sinusitis can last long. So many a time this is rhinosinusitis, or sometimes it's called simple sinusitis, and the symptoms gonna be, patient would be having many a cases preceding history of rhinorrhea, flu, nasal congestion, nasal obstruction, and lately the person would come up with a symptom that I'm having headache now, and this headache worsens as I bend my head, as I go in sajda position during the prayers. I feel that this headache worsens. This is a classical feature of sinusitis. Moving to these two things now. The same person, the same boy, 5-year-old, now claims that now I am having cough with expectoration, cough with sputum. So that sputum is sometime whitish color, sometime yellowish color, sometime greenish color. So now the infection has spread to the bronchi. So as it has spread to the bronchi, there would be sputum production, and ultimately the patient would be coughing it out. Patient can have low-grade fever besides that cough. And most of cases of acute bronchitis are not bacterial. They are viral, but occasionally the bugs like Mycoplasma, few others, Moraxella, they can cause acute bronchitis. Sometimes even the Streptococcus pneumoniae and this H. influenza, they can cause this thing as well. And then community acquired pneumonia. The same person now claims that he would be coming up with a little bit change in his symptoms, that now my fever has become high grade with rigors and chills. I'm having chest discomfort, chest pain as I breathe in deeply. As I inspire deeply, I feel pain over, say, my right lower chest. And patient would be saying, as I cough, again I am having that feeling of pain in lower chest. One thing, high-grade fever with rigor chills, pleuritic symptoms may be accompanied, and then besides that, a person can have cough with expectoration. So this highly likely gonna suggest that person is a case of community acquired pneumonia. This is how you're gonna catch these diseases. And within next 3 to 5 minutes, we'll be discussing their major treatment plan. Whenever you are going to discuss treatment of anything, remember it should be discussed as the first limb will be of supportive, symptomatic or conservative therapy. Like if a person is having, I will be dividing these things in 2 different parts: pharyngitis, laryngitis and tracheitis. These will be taken as together, and similarly this acute bronchitis. I'll discuss all these 4 things together, and then this thing, tonsillitis, will be discussed in isolation, sinusitis in isolation, and pneumonia in isolation. These are the serious respiratory problems. These are the very minute respiratory problems, right? So talking about pharyngitis, laryngitis, tracheitis and acute bronchitis, supportive symptomatic therapy. For pharyngitis, you would be asking the patient to do gargles. The best way to do gargles is to put salt in lukewarm water and do these gargles thrice daily or 4 times a day. Sometimes aspirin can be added to it. That gives you significant relief if person is finding it difficult to swallow things and having throat irritation. The next is paracetamol. Paracetamol would be for fever, associated fever, and if somebody is having that pain, obviously you can add things like NSAIDs, brufen for the symptoms of inflammation, to lower down the inflammation. Not necessarily in all the cases, because many a time when people start taking these NSAIDs, they start having GI symptoms in addition to it. So it's not necessary in all the cases. It's just kind of a thing which you can add if person is having significant problem. And if it gets complicated and patient is finding severe difficulty in swallowing, even on occasions, steroids can be added for a very short time. High dose steroids for 2 to 3 days can be added in these settings. Laryngitis, again, the gargles do help in these cases for relief of that hoarseness. Rest, giving rest to your throat by not speaking a lot, obviously that helps you as well. Similarly, tracheitis would be just managed simply with the aid of paracetamol and occasionally few other things which reduce inflammation like these NSAIDs can be tried. Acute bronchitis. The person with acute bronchitis can have coexistent wheezes. If they are having coexistent wheezes, then they may be in need of bronchodilation. So you can add those bronchodilators in those settings. For fever, again, simple supportive therapy, paracetamol. If there are certain things in all these 4 situations, symptoms you have not been able to manage symptoms well, this is lingering on, things are not settling down, you are living in an area where you expect that person may have beta hemolytic streptococci as the bug causing the infection, then this can be very hazardous and this can lead to a lot of serious complications. You all know it well, that can lead to rheumatic fever lately. So for all these cases where we are suspecting a bacterial infection, actually one should get that antigen test done to look for those organisms, or one should take that throat swab. But we do not get this thing in our setting in all the cases. And even in developed world, if they get these tests done, the results are available after 2-3 days. And usually that is the time during which infection settles at its own. So if we are suspecting bacterial infection, how to manage all 4? Now the group of antibiotics which we'll be using for these conditions would obviously be covering all those important bugs which lead to these problems. So these important bugs are H. influenza, Streptococcus pneumoniae, Moraxella catarrhalis, and the atypical ones like Mycoplasma, like Chlamydia, and like Legionella. So these are the bugs which can lead to these sort of problems. Classically, these are the pneumonia causing bugs, but in all these conditions they can contribute. How to manage? 3 groups, 1, 2 and 3 group of antibiotics. The first one is penicillin. So amoxicillin either in isolation or with clavulanic acid like augmentin. So this is one of the group, penicillin. Second is macrolides, azithromycin or clarithromycin. Clarithromycin has got bad taste, azithro is very good in that sense. So the second option is azithromycin, comes in doses of 250 milligram or 500 milligram. Augmentin comes in strength of 500 by 125, total is 625, and then 825, 175 comes in strength of 1 gram. The third group is then respiratory tract fluoroquinolones. Respiratory tract fluoroquinolones come with the name of levofloxacin and moxifloxacin. So these are the antibiotics which can be used preferably. This would be the choice. If patient is penicillin sensitive, then other things can be tried. Amoxicillin, clavulanic acid in all these conditions, if you are suspecting a bacterial infection, can be given for 5 to 7 days. Azithromycin, a very good thing about this drug, you have to take it once daily. I am talking about adult medicine here, no pediatric medicine here. We are here dealing with the cases above 16 years of age. So azithromycin comes in strength of 250 and 500. So what is the benefit of giving this drug? We need to give it once daily for 3 days in all these states. 3 days enough, once daily is the dose. Then levofloxacin 500 milligram once daily for 5 days, that's enough. Moxie 400 milligram once daily for 5 days, that's enough. So these are the 3 groups, these are the 4 infections. Considering bacterial infections, this is the way you're gonna treat along with symptomatic and supportive therapy. Coming to tonsillitis. Tonsillitis, the book recommends amoxicillin clavulanic acid is the drug of choice. The most important point I want to highlight, why people do not get better when they succumb to tonsillitis. They do not take antibiotics for proper duration. The book write down 10 days, not lesser than 10 days, not 9 days and 8 days, always 10 days. And what happens? Most of us, when we are dealing with this problem or dealing with our family members or people around, as soon as the patient's symptoms would be settling down, they would not be taking this drug anymore. And what will happen then? They would be coming after 1 month again, after 2 months again, after 3 months again. The streptococcal carrier many a time reside inside these tonsillar crypts, and that just keeps on, that infection just keeps on coming and coming and coming. So the most important point is take it for 10 days. 1 gram twice daily or 25 milligram thrice daily. That's the drug of choice. The next is then levo and moxifloxacin, azithromycin can be tried in certain cases. So that's about tonsillitis. If the pus is there in the tonsils, you need to remove it. The answer to pus is always one and only incision and drainage. The third is then, next infection is then sinusitis. I have already told you the trigger behind that sinusitis is the nasal congestion and blockage. So you need to relieve that obstruction and blockage. For that purpose, the best thing in our hand is xylometazoline. Here in Pakistan come with the name of Zynosine. You take this thing, immediately that nasal obstruction is opened. Additionally and rather preferably the intranasal corticosteroids, they can be tried. They reduce the inflammation and they help in obstruction. So that's another important thing you must give in the setting of sinusitis as far as antibiotics are concerned. As far as antibiotics are concerned, again the answer is same. Amoxicillin clavulanic acid, first choice levomoxifloxacin, and lately azithro can be tried even in these settings. Additionally, you would be managing patient symptomatically and you would be offering him or her supportive therapy. Last is community acquired pneumonia. Because they are acquired from community, they are known as community acquired pneumonia. They can be of 2 types, typical and atypical one. The typical ones are the 6 bugs are the bugs commonly responsible, 3 responsible for the typical ones and 3 responsible for the atypical infections. The infections caused by the typical ones, one is Streptococcus pneumoniae, second is H influenza, third is Varicella catarrhalis. And as far as the infection caused by the atypical ones are concerned, Chlamydia, Legionella and Mycoplasma are responsible for this atypical infection. And occasionally, if patient is having certain risk factors underneath, there is some structural lung damage, then the bugs like Staph aureus, like in IV drug abusers, the bugs like Pseudomonas can be culprit in some cases, not necessarily in all the cases. So person suffers from community acquired pneumonia. How to manage it? You have to offer them drugs based on certain criteria that whether this patient should be managed on outdoor basis or indoor. So as far as this pneumonia is concerned, the most important point is that you have to differentiate whether this person needs treatment indoor or outdoor. And what have you got in your hand? You have got curve 65. This curve 65 scoring will help you. Confusion, urea levels more than 45 milligram per deciliter, respiratory rate more than 30, and blood pressure 90-60, below 90-60, and the age is above 65. If any of point is present, out of these 5 points, if any single point is present, a patient can have brief in hospital stay, more points are added, a patient is in need of hospital stay. Answer to community acquired pneumonia is again the same. These all three things can be tried. Azithromycin is usually given for 5 days, amoxicillin for 7 days, levo and moxi usually for 5 to 7 days. Thank you very much.